Welcome, everyone, to our Heart Health Lecture Series, which is brought to you from the Center for the Prevention of Cardiovascular Disease at NYU Langone Health. We thank you for joining us, and I'm sure, as I am, you are looking forward to our fantastic lecture for tonight, which will be all about hypertension. Next slide. So I'm Dr. Dennis Goodman. I'm clinical professor in the Department of Medicine. I'm Director of Integrative Medicine, and I'm a cardiologist in the Center for the Prevention of Cardiovascular Disease. And I founded this lecture series, which I'm really proud of. And I also want to give a shout out to Anya Coates, who does a fantastic job helping me with this particular program and making it happen. Thank you, Anya. Next slide. So just to remind you, I think many of you are regulars, and you know that if you have a question, you go to the Q&A box, you can type the question in. I'll be fielding the questions. I'll ask as many as I can. We've also had several questions sent in already. So we have a full Q&A at the end of Dr. Blau's presentation. Next slide. The upcoming webinars are two that that'll be presented before the summer recess. The Environment and Cardiovascular Disease on Wednesday. If you go back a second, Anya. On Wednesday, April 19th, please note the time, it's 12 to 1 p.m., not the usual 5 p.m. And then we're going to do Improving Heart Health and Health in General through Your Gut Microbiome, very hot topic. That's Wednesday, May 10th from 12 to 1 p.m. You can register by going to nyulangone.org/heart health lectures. Next slide. There are many ways to be, just to remind you that this is actually a program, this is one of our programs. We've had over 50 programs so far on many topics here. You can just see some of the topics. Women, we did women and heart disease. We did that last month. Exercise, the microbiome, pre-diabetes, hypertension in the past and again today, diabetes, pollution, stress, sleep, prevention, cigarette smoking, mind, body, immune system, etc., etc. Next slide. Many of these lectures have been recorded, and you can go to the lecture library on YouTube, and you can listen to any one of these lectures, and tonight's lecture will also be recorded. You can go to the website that I gave you, and that'll give you a link to the YouTube lectures. Next slide. Here's another way that you can get in touch with us. The website is nyulangone.org, Heart Health Lectures. That one I told you about. And then there's an email, hearthealth@nyulangone.org. And then we've got on Instagram and Twitter at NYUCVDPprevent. Next slide. So you all know how strongly I feel about prevention, the four legs of the stool, nutrition, exercise and flexibility, stress management and sleep, and many of the lectures that I present to you and I helped get speakers are related to these four topics because we want your stool to be sturdy and steady. If one of the legs is not sturdy and steady, then you're going to fall off the stool. And so prevention is the key to good health. And as you know, this lecture series is focused primarily on prevention. Next slide. So it's my great pleasure to introduce our speaker for tonight. He is a colleague of mine in our Prevention Center and Program at NYU Langone. He's also a clinical assistant professor of medicine and a faculty member of the NYU Center for the Prevention of Cardiovascular Disease. He is in clinical practice at NYU Ambulatory Care, Lake Success Cardiology in Long Island. He's been in practice for 30 years. He's a fellow of the American College of Cardiology, of the American Society of Preventive Cardiology, and the National Lipid Association. He did his fellowship at Northwell, where he also did all his training. Dr. Blau, it's an absolute pleasure to have you on. I know what a great asset you are to our faculty and our program, and we're delighted to welcome you to our lecture series. So over to you.
Thank you so much, Dennis. It was a very kind introduction, and thank you for the opportunity to speak on this very important topic. I'm going to be speaking about high blood pressure. The topic is entitled, All You Need to Know to Prevent Heart Attack and Stroke. Next slide. This is a brief outline. What is hypertension? Why is it important? What are the different types of hypertension? The SPRINT trial, how that is important, how we manage our patients. What are the different ways to monitor our blood pressure? The different devices for home blood pressure monitoring and other types of monitoring. What are the treatment options? What is the goal of treatment? How do we manage lifestyle and modifications to manage hypertension, along with medications, and when are they indicated? Next slide. High blood pressure remains the leading modifiable risk factor globally for attributable premature cardiovascular deaths. Close to 11 million cardiovascular deaths in the year of 2021. It increases the risk of myocardial infarction or heart attack, stroke, congestive heart failure, and atrial fibrillation. Next slide. This is a pictorial from the American Heart Association displaying this, along with increased risk of kidney disease, ophthalmologic disease, and sexual dysfunction. Next slide. There's an association between blood pressure level and the risk of myocardial infarction, stroke, and total mortality. This was demonstrated by the cardiovascular health study. There is generally an increasing or linear association of the risk of myocardial infarction with increasing levels of blood pressure. High blood pressure makes the atherosclerotic plaque more unstable. Left ventricular hypertrophy, which is the thickening of the heart muscle, is the usual complication of hypertension and contributes to myocardial ischemia. Next slide. Hypertension is the most prevalent risk factor for stroke, seen in close to 2/3 of patients with stroke. There are three main types of stroke, the most common being ischemic in close to 87% of patients, intracerebral 10%, and subarachnoid hemorrhage in 3%. FDR, one of our presidents, died of uncontrolled hypertension and intracerebral stroke and bleed. A previous heart health lecture series is on the YouTube playlist in terms of who is at risk of stroke to kind of look into this in more detail. Next slide. Hypertension causes stroke, as I said, through it could be ischemic or hemorrhagic. Also, white matter lesions develop, which are silent brain infarctions that can occur in patients and may increase the risk of vascular dementia. Hypertension increases the risk of atrial fibrillation, which as well can increase the risk of stroke. Next slide. So this slide is just meant to demonstrate how increasing blood pressure increases one's risk of stroke. So the left side here is a cumulative incidence of stroke, and this is starting, the top graph is starting at age 30 to age 60, and this top line here, which is separated from all the others, is patients with stage 2 hypertension. So the left here describes the different stages of hypertension, which I'll discuss in more detail in just a few moments. Next slide. I think this slide is very important to understand. For every 20 millimeters rise in systolic blood pressure, there's a doubling of mortality from both ischemic heart disease and stroke. So I really can't point for you, but if your numbers go from 20 to 40 on the bottom here, the risk doubles from 5 to 10 in terms of your absolute risk of stroke mortality. Next slide. A number of trials have demonstrated the association between long-standing hypertension and congestive heart failure. Practically 30% of patients will develop heart failure. The SPRINT trial, which we'll discuss in a little while, demonstrated the reduced risk to progression of heart failure in patients in the more intensive blood pressure control arm versus the target blood pressure arm. This is a picture of Ted Williams, who died of congestive heart failure related to hypertensive heart disease. Next slide. As I mentioned, hypertension increases the risk of atrial fibrillation in close to half of men and women. Hypertension accounts for the most cases of atrial fibrillation than other risk factors, and seen in an overwhelming majority of patients. Next slide. So what is essential hypertension? Well, in most people, no specific cause of high blood pressure can be identified. As much as 95% of people with high blood pressure have essential hypertension. The probability increases with age. Secondary hypertension is more common in younger individuals. There are certain high-risk groups. African Americans have a greater risk of developing hypertension than Caucasians. Men are more likely to develop high blood pressure than women, and at an earlier age. After menopause, women become more susceptible to high blood pressure. Next slide. So to the left here are the different blood pressure categories. from the American Heart Association and the American College of Cardiology. So normal blood pressure is defined as both a systolic less than 120 and diastolic less than 80 millimeters of mercury. Elevated blood pressure is a blood pressure of 120 to 129 systolic and diastolic less than 80. Stage 1 hypertension is defined as a systolic blood pressure of 130 to 139 or a diastolic of 80 to 89. And stage 2 is a systolic blood pressure greater than or equal to 140 or a diastolic blood pressure greater than 90. Next slide. White coat hypertension and masked hypertension are two other types of hypertension that I just want to briefly mention. Most people are more familiar with the white coat hypertension when the office blood pressure is elevated, but out of office blood pressure readings are normal. Masked hypertension is when office blood pressure readings are normal, but out of office readings are elevated. Next slide. The SPRINT trial was one of the landmark trials in terms of establishing the effectiveness of treating blood pressure. It was initially published in 2015. There have been a large number of studies since then doing different analyses of them, and a more recent final analysis report in 2021. And as I mentioned, it demonstrated the effectiveness of treating systolic blood pressure to levels that were well below those previously recommended in the United States and Europe. Next slide. They recruited more than 9,000 adults over the age of 50 who had increased risk of cardiovascular disease and had an average systolic blood pressure of 130 to 180 systolic. They were randomized either a blood pressure treatment goal of less than 120 in the intensive arm or less than 140 in the standard arm. The primary outcome was a composite of myocardial infarction, stroke, acute coronary syndromes, acute decompensated heart failure, and cardiovascular death. The drug treatment regimens were recommended based on the best evidence from clinical trials, but the ultimate choice was made by the physician site investigators. Next slide. The sites were provided an Omron oscillometric blood pressure device. You can see the median readings, less than 120 in the intensive group, less than 140 in the standard group. The inclusion criteria, as I mentioned, the presence of hypertension, greater than 130 systolic, age greater than 50, and at least one risk factor for heart disease, which could have been clinical or subclinical cardiovascular disease other than stroke, chronic kidney disease, a Framingham risk score, 10-year risk greater than 15%, which I'll explain a little later in the presentation, and age greater than 75. Next slide. The trial was terminated early due to overwhelming evidence of benefit. The trial indicated that intensive blood pressure lowering to a target less than 120 millimeters systolic was superior to routine management with a target less than 140 millimeters of mercury in high-risk, non-diabetic patients with hypertension. And the primary outcomes that I just mentioned previously was significantly lowered in the intensive blood pressure management arm compared to the routine management arm. Next slide. The reduction of the primary outcome events in the intensive treatment groups was also seen in a number of subgroups, such as age, gender, levels of baseline blood pressure, presence or absence of cardiovascular disease, chronic kidney disease, and race. Next slide. This slide is meant to demonstrate the difference between the intensive and the standard treatment arm. You can see the intensive treatment arm, the cumulative hazard ratio is lower, showing the benefit over a number of years. Next slide. The predicted magnitude of benefit in the intensive standard treatment arm in terms of absolute risk reduction grew linearly as the baseline risk increased. What that really means is those at highest risk derive the most benefit. That's seen in a lot of studies that we do in patients with heart disease. The baseline factors that were more strongly associated with higher risk were older age, history of cardiovascular disease, and kidney disease. Next slide. More specifically, in terms of cardiovascular outcomes, the primary outcome and all-cause mortality were 25 and 27% lower in the intensive treatment arm. There was a 43% reduction in cardiovascular death, 38% reduction in acute decompensated heart failure. The intensive strategy reduced the risk of developing left ventricular hypertrophy, which is thickening of the heart muscle, among patients without baseline hypertrophy, and also resulted in greater regression of hypertrophy in those with evidence of baseline left ventricular hypertrophy. That is important because patients with left ventricular hypertrophy have a greater risk of heart failure and atrial fibrillation. Next slide. As I mentioned, there was a 38% reduction in acute decompensated heart failure in the intensive arm. And this is consistent with a number of other studies that have demonstrated that as well. Next slide. Stroke was not significantly reduced in the SPRINT trial, but the intensive blood pressure treatment arm resulted in a reduction in mild cognitive impairment during the trial and a composite of mild cognitive impairment and probable dementia during a combined trial and post-trial follow-up. Next slide. This was a study that was just published earlier this year in the Journal of American Medical Association and is entitled The Association of Intensive versus Standard Blood Pressure Control with Regional Changes in Cerebral Small Vessel Disease Biomarkers. And it's what we call a post-hoc secondary analysis of the SPRINT Mind randomized clinical trial. And what they found was that the intensive blood pressure treatment arm was associated with a slower increase in white matter lesions, improved other imaging findings on MRI in areas of the brain that represent vulnerable areas that would potentially benefit from more strict blood pressure control. Next slide. So what are the adverse effects of more intensive blood pressure treatment? Well, the adverse events that were monitored for were hypotension or low blood pressure, syncope or passing out, falls, and acute kidney injury. The intensive treatment group did have a greater risk of low blood pressure compared to the standard arm. There was not a significant difference in the other findings. Next slide. One concept that I think is important to understand is that, blood pressure is not just check your blood pressure a couple times a year in the office setting, and therefore it's controlled or not controlled. So the concept of what's called time in range is looked at to try and see what percentage of time a patient blood pressure may be in range. So this is a post hoc analysis of the SPRINT trial. And they aim to try and find association between the time the blood pressure was in a target range and what's called major adverse cardiovascular events, or MACE, among adults with hypertension. And what they found that a greater time in therapeutic range for systolic blood pressure was associated with a decrease in these events. I'll discuss this a little bit later with one of the devices that are used to monitor blood pressure. Next slide. So how do we measure and monitor one's blood pressure? There are office measurements. There's 24-hour ambulatory blood pressure monitoring and home blood pressure monitoring. Next slide. So the first step is knowing your numbers, and that's blood pressure amongst other things we'll discuss, and knowing that you have an accurate reading. So whether you're doing it at home or in the office, it's important for the 30 minutes before, that shouldn't have any caffeine, no exercise, obviously no smoking. The 5 minutes before your blood pressure is taken, sit still, resting, and then make sure the cuff is the right size in the right place, that your arm is on a flat surface at your heart level, and sit in a comfortable position without talking. And then repeat the reading once or twice and average the 3 readings. Next slide. So 24-hour ambulatory blood pressure monitoring devices are available. There are blood pressure monitors that are connected to your arm with tubing that measures your blood pressure every 15 to 30 minutes over 24 hours. After 24 hours, the monitor is returned, the data is downloaded. We're able to determine the 24-hour average blood pressure, the average daytime blood pressure, nighttime blood pressure, which becomes relevant, which I'll discuss, and the calculated percentage drop in blood pressure at night. Next slide. Unfortunately, there's limited coverage for the ambulatory blood pressure machines. Predominantly, it's indicated for suspected white coat or masked hypertension once per year. There are other indications that it may or may not be covered, and it's at really the discretion of Medicare and the managed care companies. Next slide. So checking your blood pressure at home is an important part of managing blood pressure. The American Heart Association recommends that people with high blood pressure monitor their blood pressure at home. This helps with early diagnosis, tracking your treatment, and encourages better control. Monitors are available widely without a prescription. It's important to know how to find a good blood pressure monitor, which I'll discuss with you shortly, and how to use it properly. Next slide. It's best to use a digital monitor that's fitted to your upper arm. These are felt to be more accurate than a wrist monitor. Some people with very large arms, though, may have difficulty finding access to a well-fitting arm cuff. In those patients, a blood pressure wrist monitor may be okay. It's important to check the accuracy of your monitor by bringing it to your provider's office and comparing it to your readings that are taken in the office at that Next slide. Sit quietly before and during monitoring. Make sure your arm is positioned properly. As I mentioned, rest your arm raised to the level of your heart and place the cuff on bare skin, not over clothing, and take a repeat reading. Next slide. It's important to use a validated device. Most of the devices that we use are what's called oscillometric. There's a list of validated home monitors at the website validatebp.org. There are also a number of monitors that are validated in England and in Europe as well. Again, upper arm devices are more reliable than wrist devices. And many of these have smartphone apps that allow you to track your blood pressure, log them in, and generate a lot of data. Next slide. This is a picture of a few different blood pressure devices. There are obviously many of these that are available. Next slide. Just want to talk briefly about wrist devices. So the arm devices are clearly less expensive. The wrist devices priced a lot higher, but probably the technology will be evolving over time to make them hopefully more beneficial. But specifically, this is one called the Omron Heart Guide. It may be hard for you to see, but inside the wrist monitor, there are cuffs that inflate and deflate. And this is, there are miniaturized components for the traditional oscillometric measurement. So there's an inflatable cuff within the watch band to take blood pressure readings. Next slide. So a device that's being developed in Europe it's made by a company called Actia, and it looks at the continuous monitoring of blood pressure using a wrist-worn cuffless device. So if you look on the inside of this device, there's no cuffs inside. It doesn't inflate or deflate, and it provides blood pressure values using photoplethysmography technology, and it analyzes the changing diameter of the arteries occurring beat to beat. This is done automatically, so users are not aware and stressed. They do not have to interrupt their day or their sleep to take a measurement. Next slide. This is validated for accuracy in Europe. Like I said, it's not yet available in the United States. It automatically triggers about 150 readings per week, both while awake and sleeping. And it's the only solution able to measure a patient's time in range. Again, the percentage of time your blood pressure is within a healthy range. Next slide. There's an ongoing study at the Brigham and Women's Hospital, which is going to be completed early this year, called the Cool Blood Pressure Study. And this is part of their remote hypertension program. It's investigating the data provided by this cuffless blood pressure monitor at the wrist, integrated into their hypertension program, comparing it to more standard traditional home blood pressure devices. Next slide. So when do we start treatment for patients? Well, all patients in what I highlighted here should be treated with non-pharmacologic therapy, whether you have elevated blood pressure, stage 1 hypertension, or stage 2 hypertension. Next slide. What is the recommended blood pressure goal? Well, for adults with confirmed hypertension and known cardiovascular disease or 10-year atherosclerotic event risk of 10% or higher, which I'll explain in just a little while, the blood pressure goal is less than 130/80. Next slide. So why did the hypertension guidelines recommend a blood pressure target less than 130/80 when I just spent a lot of time explaining the SPRINT trial with a systolic blood pressure of less than 120 showing benefit? Well, there's some thought that some of the blood pressure measurements in the SPRINT trial were unattended, therefore may have been somewhat lower than attended blood pressure readings. It's there's definitely some discussion and criticisms on both sides, but ultimately the guidelines have recommended a blood pressure less than 130/80 rather than less than 120/80, but still less than the 140. Next slide. So when we start talking about dietary therapy, this was a study published in the New England Journal in 1997 about dietary approaches to stop hypertension, or the DASH diet. And this looked at 459 adults with systolic blood pressure less than 160 and diastolic 80 to 95. For 3 weeks, the patients were fed a diet that was low in fruits and vegetables, had dairy products and a fat content typical of the average American diet. Then they were randomized to either be on the control diet, the diet rich in fruits and vegetables, or a combination diet that was rich in fruits and vegetables, had low-fat dairy products, and reduced saturated and total fat. Sodium intake was consistent amongst everybody at 3,000 milligrams. Next slide. And if you look at this graph, the top bars is patients with a controlled diet. The middle is the patients that were on the diet that was was enriched with fruits and vegetables. And the bottom is the combination diet. And you can see that the blood pressure decreased. Systolic is the top and diastolic is the bottom graph in both groups of patients at 8 weeks. So in conclusion, a diet rich in fruits, vegetables, and low-fat dairy foods with reduced saturated total fat can substantially lower blood pressure, and such a diet offers an additional nutritional approach to the prevention and treatment of hypertension. Next slide. This is a picture of the DASH diet, enhancing intake of grains, lean proteins, legumes, nuts, seeds, limited fats and sweets, low-fat dairy products, and a diet that's enriched with fruits and vegetables. Next slide. So you may have noticed that the 3,000 milligrams of sodium seems like a large amount of salt in the diet. So subsequently, there was a study looking at the dietary approaches to stop hypertension and then looking at different sodium intakes. This was a little over 400 adults given the typical American diet or a DASH diet at 3 different sodium levels: 3,300 milligrams, 2,300 milligrams, and 1,500 milligrams. Next slide. And what they found was that reducing daily sodium lowered blood pressure for participants in either diet. The DASH diet plus the low sodium diet, 1,500 milligrams or about a half a teaspoon of salt, lowered blood pressure more than the typical American diet at all 3 daily sodium levels. Blood pressure decreased with each reduction in sodium, and most importantly, reducing sodium intake and following the DASH diet was found to be more beneficial for lowering blood pressure than following the DASH diet alone or reducing sodium alone. Next slide. The DASH diet also incorporates a diet that's replete with potassium, calcium, and magnesium, and is being recommended as a standard lifestyle modification for patients with hypertension. The DASH diet recommends a daily intake of 4.7 grams of potassium. Next slide. Is there such a thing as too much potassium? Well, the answer is yes. Specifically in patients with chronic kidney disease may have difficulty excreting potassium, so the levels may become elevated, which can have adverse cardiac effects in terms of heart rhythm. Certain medications as well you may retain potassium, such as ACE inhibitors, angiotensin receptor blockers, and medicines called aldosterone antagonists. And ultimately, you really need to discuss this with your physician if a high potassium diet is safe for you to help lower your blood pressure. Next slide. Exercise is obviously an important component of managing your cardiovascular risk. Exercise achieves a reduction in body weight, reduction in blood pressure, reduction in bad cholesterol, improves good cholesterol, and insulin sensitivity. Next slide. How much exercise is enough? Well, even 30 to 60 minutes of exercise per week was sufficient to reduce both systolic and diastolic blood pressure in patients with stage 1 and stage 2 hypertension. The magnitude of reductions was greater in those that exercised 61 to 90 minutes per week rather than 30 to 60 minutes per week. Next slide. And these are the current guidelines for exercise for patients with hypertension and cardiovascular disease. At least 150 minutes of moderate intensity exercise per week, or 75 minutes of vigorous intensity exercise, along with at least 2 days of muscle strengthening, and the basic concept of trying to sit less and move more throughout the day. In patients over the age of 65 who may have difficulty doing this amount of activity, it's important to be as physically active as your abilities allow you, and to also perform multi-component exercise and balance training. Some examples of moderate intensity exercise include brisk walking, recreational swimming, slow bicycling, and doubles tennis. Next slide. Moderation of alcohol intake is important, as patients that either moderate drinkers or heavy drinkers clearly have an increased risk of both stage 1 and stage 2 hypertension. Next slide. Maintaining a healthy body mass index, or BMI, is important. Normal body mass index is up to approximately 25. And as your weight goes up, your increase of various comorbidities increases, including hypertension. Next slide. This slide is a little difficult to see, but I incorporated because I wanted to kind of make the point that the body mass index for each individual is different across different ethnicities. So this relates to obesity and diabetes risk. And I don't have a pointer, so I apologize, but this black line going across horizontally here is average risk. And this red line here is Caucasian population. Bottom here is a BMI of 25 for white population. As this line starts to go up, that's associated with increased risk of diabetes. This blue line here, which is skewed to the top, is patients of South Asian descent. And if you track it down, you can see when the body mass index is above 19, they have a greater risk of diabetes. So it's important to understand one BMI is not equivalent for all ethnicities for diabetes risk. But again, it's important to know your body mass index. Next slide. So obesity, as I just mentioned, increases the risk of high blood pressure, diabetes, heart disease, heart failure, and various types of cancer. Weight loss is clearly associated with a decrease in blood pressure as well as numerous other improvements in your medical status. Next slide. The Framingham study demonstrated that both men and women had an increase in blood pressure with increased weight. For approximately every 4.5 kilograms or approximately 10 pounds of increased weight, your blood pressure went up by about 4 millimeters of mercury. Loss of weight lowers blood pressure. Next slide. The treatment of obesity, as I mentioned, includes lifestyle modifications, dietary restrictions, exercise, reducing alcohol intake, screening for obstructive sleep apnea. Bariatric surgery, which is not the subject of this talk, though, is an accepted treatment for obesity, achieving remission of hypertension in a large number of patients. Class of medicines called GLP-1 agonists. People are very familiar with medicine called Ozempic, which is used for diabetes, also promotes weight loss and has indications for weight loss with its medication called Wegovy for weight loss, amongst other medications. Next slide. Sleep and hypertension and sleep inefficiency is becoming more important. We're learning a lot about how sleep affects cardiovascular risk. There have been a number of studies showing correlations between sleep deprivation and various adverse cardiovascular risks. People with poor sleep patterns have a higher risk of hypertension. In particular, people who sleep 6 hours or less may have a steeper increase in blood pressure and ideally should get at least 7 or 8 hours of sleep. Next slide. Obstructive sleep apnea is associated with hypertension as well. These two conditions frequently coexist in close to half the patients. Patients with sleep apnea typically have non-restorative sleep, daytime sleepiness, and snoring, and these may be some of the clinical clues to pursue this diagnosis. Prescription of CPAP as a treatment for sleep apnea may help lower blood pressure and risk, along with weight loss. Next slide. So just to summarize the diet and lifestyle modifications, sodium restriction to less than 1,500 milligrams per day, increased dietary potassium if clinically appropriate, weight loss and maintaining a healthy body mass index, appropriate physical activity, moderation of alcohol intake, and a healthy DASH-like diet rich in fruits, vegetables, whole grains, low-fat dairy products with reduced saturated and total fat. Next slide. So highlighted here is when do we start recommending pharmacologic therapy or medication? So in patients without ASCVD, so first focus on patients with stage 1 hypertension who have, after 3 to 6 months, who are not at goal, that's when you consider medication, who do not have atherosclerotic coronary vascular disease and a 10-year risk less than 10%, and I'm going to explain that to you in just a moment. Or pharmacologic therapy is recommended if you do have those parameters, along with anybody in stage 2. Next slide. So what is ASCVD? Well, that stands for atherosclerotic coronary vascular disease. For the definition of documented ASCVD, both guidelines include acute coronary syndromes, stable angina, coronary revascularization, whether you've had a stent, bypass, history of stroke, transient ischemic attack, or peripheral arterial disease. Next slide. Many of you may be familiar with your 10-year cardiovascular risk. This is another important number to know. It's generated by something called your pooled cohort risk equation, and it's based upon your gender, your age, your race, your cholesterol, your good cholesterol, your systolic blood pressure, and presence or absence of diabetes, hypertension, or smoking. Next slide. So what are the recommendations for choice of initial medication? So first-line agents are recommended to be thiazide diuretics, calcium channel blockers, such as amlodipine, ACE inhibitors, or angiotensin receptor blockers. A single medication may be reasonable in adults with stage 1 hypertension with a blood pressure goal of less than 130/80, and dosage titration and sequential addition of other medications to get to your blood pressure goal. 2 first-line agents of different classes are usually recommended in adults with stage 2 hypertension or an average blood pressure more than 20 millimeters systolic or 10 millimeters diastolic above their target, reflecting back to the graph that I showed you earlier about how the doubling of risk for every 20 millimeter rise of systolic blood pressure. Next slide. There are certain groups of hypertension where other medications may be recommended. In patients with what's called ischemic heart disease, what's called beta blockers are often recommended as part of the guideline-directed medical therapy. Next slide. Patients with diabetes who may have protein in the urine or albuminuria, ACE inhibitors and angiotensin receptor blockers may be first-line therapy in those patients. Next slide. For Black adults with hypertension, initial antihypertensive therapy that's recommended is thiazide diuretics and calcium channel blockers, typically prior to ACE inhibitors or angiotensin receptor blockers. Next slide. One question that a lot of patients ask is, does it matter taking your medication during the day or at night, bedtime? Well, the morning blood pressure surge has a significant increased risk of cardiovascular events. Normally, a patient experiences what's called nocturnal dipping while sleeping at night, or your blood pressure going down by about 10 to 20%. In some patients, the blood pressure may not dip or even experience a rise in blood pressure during sleep or a non-dipping pattern. Next slide. There was a study, a Spanish study, that suggested that taking your blood pressure medicine at night cuts the risk of heart-related death in half. A subsequent study published this year in the European Society of Cardiology Congress of more than 21,000 patients concluded that protection against heart attack, stroke, and vascular death was not affected whether the medicine is taken morning or evening. There are a number of criticisms of each study. There are more ongoing studies to hopefully further clarify this. But for now, the recommendation is that evening dosing of blood pressure medicine is not better than morning dosing. Next slide. What is important is once daily dosing rather than multiple times daily is more beneficial to improve compliance and adherence to medication, whether you take the medication morning or evening. Next slide. So where does the future lie? Well, there are certain medications called small interfering RNAs that target what's called angiotensinogen. There's something called CRISPR gene therapy, where there's deletion of a specific angiotensinogen gene. Renal denervation is not necessarily a new concept, but its role for management of a more resistant hypertension is being better clarified in some patients. In my view, what still would have the greatest impact on reducing the future incidence of hypertension and its consequences, clearly improved dietary habits, exercise, and maintaining a healthy body mass index. This should start with children, in adolescence, and obviously extending into adulthood. Next slide. So in summary, hypertension is a leading risk factor globally for cardiovascular disease, including myocardial infarction, stroke, congestive heart failure, and atrial fibrillation. There are 4 blood pressure categories that help define treatment recommendations for non-pharmacologic and pharmacologic therapy. Next slide. The blood pressure goal is less than 130/80. There are home blood pressure monitor devices that can aid in management. Use a validated device. Maintain a DASH diet, sodium restricted. Increase your dietary potassium if there's no contraindication. Exercise. Next slide. Moderate alcohol intake. Maintain a healthy BMI. Get enough sleep. Be screened for sleep apnea. And take your medication daily, best once per day. Next slide. Thank you.
Thank you so much, Dr. Blau. That was wonderful. And I gave you a real tough challenge. There's so much information. You covered everything comprehensively, and I really appreciate it. So many of the questions have already been answered. I'm going to throw 1 or 2 questions out that I received during your talk, and then we'll go on to the questions that I received. I got a question on how to take your blood pressure at home. I think you covered that. I think it's the same sort of thing in the office, but maybe you could just reiterate for somebody who wants to know, when should they take it and how should they take it? If you would just go through those points that you made, I think it's really important because so many times people are taking their blood pressure at home, and then you and I know that as soon as it's slightly elevated, they keep taking it right 5 times after that, and it just goes up and up and up. So what suggestions do you have?
Well, obviously, it should be when you're sitting and resting. You shouldn't, as soon as you get home, try and check your blood pressure. But I would say, blood pressure varies throughout the day. Don't check at the same time every day. Sometimes check in the morning, sometimes afternoon, sometimes evening. Clearly vary it. Make sure you're resting for 15 to 30 minutes beforehand. Relax. Your arm should be comfortable, that the device fits properly. And that's really what I would recommend. I do think it's important for people to manage to check their blood pressure at home, because it really enables us to know how well your blood pressure is controlled to help reduce your risk. So that's what I would recommend.
I think an important thing to do is to bring your blood pressure monitor into the office, as you said, to validate it. And that'll be a good place where you'll be able to be shown how to take it. And you always want to make sure that your monitor, the readings you're getting are accurate. Otherwise, you're really in trouble when you're coming into the doctor's office with blood pressure readings. Management decisions are being made and your machine may not be accurate. I've had some patients take their monitor back to the pharmacy and say, I've just bought it, it's not accurate, and they replace it with a new one. I just wanted to point out something about hypertension, and one of the reasons that it's so important that we discuss this topic. There are over 100 million Americans, adults, with hypertension, and as you know, 50% of them don't even know that they've got hypertension, and only 25% are being controlled. So the most important thing is that people have their blood pressure taken. Doesn't matter how well you feel, you really want to make sure you're getting your yearly checkup with a physician and get your blood pressure checked. Don't be one of the people with hypertension that don't know about it, because there's absolutely something you can do about it. And we've already clearly showed you tonight how it reduces your cardiovascular risk when your blood pressure is controlled. My next question is for you is, does white coat hypertension increase your cardiovascular risk? And how can you be sure you've got white coat hypertension?
That's obviously very challenging. There are lots of patients in the office setting up their blood pressure is, very high. And that is where, checking your blood pressure at home is important, because if you check your blood pressure at home and it's always very normal, I think we could be fairly comfortable that through lifestyle modifications, exercise, diet, that you usually do not require treatment for that. I think a more complex one is the masked hypertension, people whose blood pressure is normal in the office but high outside the office. And they're all important, and some eventually may require medication. But most of the patients that are anxious in the find some anxiety in the office setting, it is clearly those are the patients that benefit from either a 24-hour ambulatory blood pressure monitor or home blood pressure monitoring.
Yeah, I have seen studies that show that people with white coat hypertension diagnosed do have increased cardiovascular risk. It's not something to be ignored. And the reason probably is that if your blood pressure is getting high when you're in the doctor's office and you see the stethoscope, it's probably getting high with other stressful situations during the day. That's why the 24-hour blood pressure monitor is so helpful. The next question is, does Ozempic lower blood pressure? I'm sure it does when you lose weight, but does it have a blood pressure lowering effect?
So I guess the question is, is the blood pressure lowering effect related to the weight loss, or is it independent of the weight loss? So I think that's a difficult question to answer. And I would, we say Ozempic. Ozempic is semaglutide. As Ozempic, it's indicated for diabetes. As Wegovy, it's indicated for weight loss. Clearly, the whole class of medicine has a lot of positive cardiovascular benefits, getting people's weight down, blood pressure, improved lipids, improved diabetic control, obviously. People are more physically active as a result of that. It's going to be hard to pinpoint that there's an independent blood pressure lowering effect. I think it's probably related to all the other things that I mentioned, that it probably helps lower your blood pressure.
Right. The bottom line is it does lower your blood pressure, and is probably significantly associated with weight loss that goes with it. Here's a bit of a tough question, but something that we are very well aware of. COVID, patients with hypertension who have COVID, do you consider using an angiotensin receptor blocker or an ACE inhibitor, considering that we know that the angiotensin receptor is one of the sites where the virus invades the body?
So first, you're correct. That's a tough question. We do know that patients with COVID have a greater incidence of hypertension, after having had COVID in the next year or two. So they should be seeing their physicians to have their blood pressure monitored. Now, whether the ACE receptor, it was more related to risk of lung disease. I'm not sure it necessarily relates to the risk of, hypertension, which is more on a renal vascular level. So I think that would require ongoing studies, which may be getting done on a research basis in patients that have had COVID, have hypertension, and then they would be randomized in a fashion to either get calcium channel blockers or ACE inhibitors. That would be the way to properly answer that question. I think the bottom line is you try a medicine and you see how well it works or doesn't work, and monitor the patient clinically.
Thank you. Okay, we're going to go to the Q&A from questions that I received from people who wrote them in. What might cause high blood pressure in someone who's had normal pressure for 60 years? I'm not sure what they describe as normal, but obviously the question is, what happens if all of a sudden you think your blood pressure is fine, it's been fine, you come to the doctor's office and you're over 60 years old and suddenly it's high? What do you think about, or is this just part of the natural history of hypertension?
So we clearly know that blood pressure increases as people get older. There have been a lot of studies in people, other than certain groups of people that are farmers and physically active. So what happens over time is, before age 50, typically your diastolic blood pressure rises due to small blood vessel vascular resistance increases. And then as you get older, the larger blood vessels become stiffer, and that causes a rise in the systolic blood pressure. And then the bottom number tends to go down, and what's called your pulse pressure, or the difference between the two, increases. And a lot of studies suggest that that's actually the thing that may increase the risk of stroke and vascular dementia the most. So it does rise as we get older, but there are things we can do to prevent that. And all the lifestyle things we discussed are important, along with making sure you're not developing hypertension, you don't develop chronic kidney disease, certain other markers in the blood that may enhance the risk of vascular disease that we look at, that you should be screened for. So blood pressure does increase normally as we get older, but it doesn't mean it has to.
I absolutely agree. I think we also very cognizant of checking for underlying. If you've always had normal blood pressure, suddenly it's high, we start to look for what we call secondary hypertension, and we will look for someone who may have a renovascular hypertension. We're looking at the renal artery to see if there's a narrowing that's developed that's causing your hypertension. Dr. Blau mentioned sleep apnea. That might be something that's crept in. Sometimes it's medications. You may be taking stuff like ibuprofen that can raise your blood pressure. You may be having too much soy. Your salt intake's high. So there are lots of other causes. There are rare causes. There are rare tumors of the adrenal that can raise your blood pressure. So it's very important that you get to the doctor, get checked, and he can check you for all these things and make sure that your blood pressure comes back down to the normal range. As you've heard today, we certainly feel that in medicine and with lifestyle changes, we can get your blood pressure back to a normal level. Okay, next slide.
I would make one more comment regarding this, if it's okay, Dennis. So a lot of patients who have had well-controlled blood pressure, all of a sudden their blood pressure is elevated. And typically that's due to one of several things. Either they're not missing doses of medicine, but more commonly there are changes in their lifestyle. They're less physically active. They're not eating the same. They've had more alcohol. There's been some dietary indiscretions. So a lot of times the changes within your lifestyle that you need to then kind of look at and then modify back to what was enabling you to control it before.
Well said. Next slide. I maintain a healthy diet, exercise regularly, and I'm a healthy weight. Yet I have high blood pressure. What could explain this? I'd like to know the age of this person asking the question, but why don't you take that?
So clearly, maintaining the healthy diet, exercising, and maintaining a healthy weight allow you to hopefully have normal blood pressure or better controlled blood pressure. But it doesn't mean you can't develop hypertension. If you have any kind of lipid, if your LDL is elevated, it can lead to calcification of blood vessels and stiffening of blood vessels. If you have glucose intolerance or diabetes, obviously smoking, but I assume this person's not smoking based on what is told here. There are other risk-enhancing factors for vascular disease, inflammatory disorders such as psoriasis, rheumatoid arthritis, lupus. There's a protein called lipoprotein A that can enhance the risk of vascular disease. So there are a lot of other reasons why someone who's taking good care of themselves can develop hypertension.
I've got a question here that came in, and I'm going to read it to you from Sarah, who says, did the studies tying obesity to hypertension, high blood pressure, and poorer cardiovascular health outcomes control for variations in people's physical activity, their diet, their cardiorespiratory fitness, as well as other risk factors for cardiovascular issues? In other words, were they able to prove that it was the weight loss itself or the other variables that often are recommended to a patient when they're advised to lose weight? We're also advising them on their diet and exercise. So it's a very good question.
I agree. That's an excellent question. I'm not sure if they adjusted for those things. I know many of the studies earlier on were trying to risk stratify and, as best they can, adjust for different levels of exercise and activity to see if the blood pressure decrease is attributable to loss of weight versus other parameters. But what happens a lot of times is when patients lose weight, they're able to become more physically active. And again, it becomes a combination of the two. And in the end, it may not be important what's causing what, because it's important to both lose weight and exercise to try and better control and lower your blood pressure.
Yeah, I think it's an excellent question, and there are studies that have looked at that. All I can tell you in my own clinical experience, most of the time people are doing weight loss with exercise and diet, but I've had many patients who actually lose weight without really working hard at exercise, and their diets have been pretty good in the first place, and they still lower their blood pressure. So there really is a direct correlation. Okay, next one. Is it possible to get off blood pressure medications once you start?
I mean, the answer is yes, but it really depends on what your blood pressure is. So, the blood pressure goal is less than 130/80, but just because your blood pressure is 120/70s doesn't mean you should be off your blood pressure medicine. It means that you're controlled and you've lowered your risk. At what level can we reduce medicine? Well, if your systolic is less than 110, diastolic, is getting into the 50s, it is possible we could start to reduce your medicine. And depending upon how many medicines or the dosage of medicines, it is possible you can come off it. I think that the question is better, to make sure that you're on the right amount of medicine, based upon your blood pressure goals and what your blood pressure is and what medicines you're on, and based upon your overall cardiovascular risk.
Yeah. I think one of the interesting things, and I've had many patients who have mild hypertension, and there are times I've had to start them on blood pressure medication, but once they start with the lifestyle changes, sometimes they've got anxiety, which gets dealt with. Sometimes it's just a change in the diet to the DASH diet. And if you can land up doing these lifestyle changes and your blood pressure comes back down to normal, and as Dr. Blau said, you'll probably land up having a lower than normal blood pressure when you're on a blood pressure pill, we can get you off the pill. So I always tell patients that, excuse me, it is possible. It's a goal to try to get off your pills, but obviously sometimes it's very difficult, especially if you're on 2 or 3 medications. I'm going to say something about magnesium in a minute, because that is one agent that does help you to reduce the number of blood pressure pills and sometimes get off them altogether. Next question. What is a safe medicine for high blood pressure? I'm not sure what they mean by safe, but let's assume they're talking about having minimal side effects and hopefully no serious adverse effects.
So, I mean, it's important to individualize your care for each patient. There are classes of medicines: diuretics, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers. Those are the medicines we use most commonly. Not one medicine is best for everybody. Not one class of medicine is best. I think you have to evaluate, and they're all well tolerated and safe medications, but you have to look at the patient's background. Do they have any underlying chronic kidney disease? What's the age of the patient? And are they on any other medications that could interact? So their medicines are safe, but it's really how they're monitored, and you have to really individualize your care and pick what's really safest for that patient.
Okay. From Betty Clark, does hypertension and endurance athletes, she wants to know, since blood pressure rises during intensive exercise and in fact any exercise, what is too much, and is there if there's a family history of coronary disease? And so I would just add to that, is there any situation where the blood pressure goes too high and it can become dangerous? And what number would you say? I'll throw out, just to not put you on the spot with this, but we do a lot of stress testing as cardiologists, and I really don't like to see the blood pressure getting up above 190 or over 200 with exercise. Most of the time it doesn't. It's very normal for blood pressure to go up to exercise, sometimes 160, 170. I'm absolutely fine with that as long as it comes back to normal. I don't know how you feel about it, but when the pressure's really getting up there, systolic hypertension, I very often try to treat the patient for blood pressure if they have baseline hypertension, but sometimes I put people on medication to avoid that so that they can exercise vigorously.
I agree with what you just said there, Dennis. You know, with exercise, systolic blood pressure goes up, and the diastolic, with the bottom number, typically goes down as the resistance in your muscles within your body decreases for enhanced blood flow. When we do stress tests, if your systolic blood pressure is exaggerated response into the low 200s, that usually indicates probably underlying hypertension. With regards to endurance athletes, it really depends upon what their baseline blood pressure is, to determine the safety of exercising to that capacity. And some patients come and do exercise stress testing just to assess their blood pressure as well and the safety.
Okay, agreed. One of our regular attenders, Stephen Ho. Welcome again, Stephen. It's always lovely to see you every time we have a program. Your question today, one of your questions, there's a notion that taking multiple drugs in low doses is good. Is there an example of such a cocktail? How do you feel about adding a second agent at a lower dose than putting people on a higher dose of a single agent?
So, dosing more than one medicine in low doses often does have a better effect of lowering blood pressure than increasing doses of medicines higher and higher. It's not like there's a linear response. Every time you double the dosage, you get a doubling of the lowering. At some point, you get a plateauing of the benefit of the blood pressure medication. Plus, certain patients will benefit more from one class versus the other. So a lot of times using lower doses of two medications may work better than a higher dose of one. And again, that's looking at the individualizing of your care for each patient and following how they respond to treatment.
I agree with you. And I think sometimes patients get a side effect from a higher dose. Sometimes we increase the dose. It doesn't work that much better than at a low dose. And when you add another agent, you get a different mechanism of action. And the two together are much more likely to be helpful. So, Stephen, there are medications that are combinations. We know what they are and we use them, and something to discuss with your doctor. Stephen, you also asked about eating 20 bananas a day causes potassium overdose. I definitely will. I hope you're not doing that. So how much is too much potassium? And what about magnesium? So I think the next question, let's just see if it's the last question. Let's see how much time we have. We got 2 minutes. Do you want to just take, Stephen, I'm going to get to your question. Do you want to just take this quickly, Dr. Blau? Lifestyle, can you speak to how adding salt when cooking or eating is minimal versus sodium in restaurants or ultra-processed food? And obviously, the question is, how much salt are we getting with processed food? And it's a lot. Do you want to just comment on that?
It's a lot. I mean, at home, you can much more easily control, the 1 teaspoon a day of sodium and the half a teaspoon if you want to be on the 1,500 milligram of sodium restricted diet. So when you go to a restaurant, you got to mention you want to have limit the salt in the food or no salt. Try and maybe put dressings and other sauces on the side, and have fresh vegetables. And that's the best way to kind of try and protect yourself from the high salt content at restaurants.
Okay, thank you. Next question. What do we do for low blood pressure? So we got to find out what the cause is, but what would you say in a nutshell?
Reduce medicine, increase your water intake. Not necessarily increase
Exactly.
your salt intake, but first start to cut back on medicine and increase your fluid intake and be reevaluated.
And I would say that it's fairly easy to treat low blood pressure with increasing your fluid intake. Sometimes we use elastic stockings. And I do tell patients, for the most part, you're better off with having a blood pressure on the lower side than a blood pressure that's very high. We haven't found significant risk in patients who have low blood pressure, as long as they're not symptomatic. Next slide. So does low magnesium levels cause a rise in blood pressure, hypertension? Are there alternative therapies? What about potassium? I am somebody that knows a lot about magnesium. I wrote a book called Magnificent Magnesium, and I feel qualified to tell you that there are studies that have shown when you have low magnesium levels, you have a risk for hypertension. The reason is that when magnesium levels are low in the body, you increase your intracellular calcium, and that causes vasoconstriction. Magnesium is a vasodilator in itself. It works similar to a calcium channel blocker. I have had many patients that have been able to lower their blood pressure by putting them on magnesium and even get them off medications if they have mild hypertension. So I'm a fan of magnesium. The dose is 3 milligrams per pound, which you can work out is about 400 milligrams a day for women and about 500 milligrams a day for men. The form of magnesium to take is something that ends in ATE, like magnesium glycinate, threonate, even citrate. But the hydroxide preparations are not good because they're not well absorbed, and they also tend to cause diarrhea. So does citrate. So if you have a problem with loose stools, avoid citrate and take malate, glycinate, or threonate. It's important to have normal potassium levels as well. It's another risk factor for hypertension. That's very easy to check because you can easily have a blood test for your potassium level at your doctor. And it's much better to, eat a banana or take some orange juice rather than taking K supplements. If you are going to take potassium supplementations, make sure that you know that your renal function is normal and check it with your doctor. One interesting thing is that there are patients who land up getting on a diuretic as a single agent for treatment of blood pressure, and a diuretic lowers your magnesium levels. So I'm big on telling patients, you're taking something to treat your blood pressure, a diuretic, but it actually causes a low magnesium level, which can cause hypertension. So always important to replete magnesium levels when you're on a diuretic. And one of the ways we do this, it's always best to do it with diet first, which is green leafy vegetables or things like sunflower seeds, things like that raise magnesium levels. I hope I've answered that. What are there alternative therapies? I've just mentioned magnesium to you, but obviously alternative therapies include things like biofeedback, stress management, yoga, meditation. Lifestyle changes in general are so important, and as an important treatment and way to lower your cardiovascular risk in general, and definitely to lower your blood pressure. Next slide. So I want to thank you, Dr. Blau. That was really outstanding. I really appreciate you talking to us. We covered the questions. They've got your phone number if they want to come see you. Otherwise, we have many doctors in our prevention program at NYU. This is one of the ways to contact us, hearthealth@nyulangone.org. We have a whole team of preventative medicine cardiologists, and we're all focused on your good health. So thank you for joining. I look forward to seeing you at our next program in April.
Thank you, Dennis.
Pleasure. Thank you.